Apologize. Like I said, you are all members of LMHPCO, and your username is your email address. Your temporary password is capital P, lowercase ASS, 1234 exclamation point. After you get in, then you can change your password to anything you want. It gives you access to member-only sections of our website. It gives you access to member rates for all of our educational products. And it also offers you an opportunity to sign up for a leadership position. We are beginning a task force on corrections that we invite all of you to be part of. And the task force simply keeps us as an organization informed as to what type of programs or issues you'd like to see us address. We are an educational corporation, and that's what we're here to do, is to help you do a better job in your facilities, in the community, wherever our members are, to do a better job caring for patients and their families. We also want to again thank the Franciscan missionaries of Our Lady Health System for making your continuing education possible through these webinars. Going to go to the next one. I did want to show you, I have now put up a one page it's just accessible to folks in corrections who log into our system. And there you can find all of these recordings that we are doing each week. You can review those along with the handouts, along with other material that you might find helpful. In order to access these materials, you simply go to the Professional Resources tab at the top and come down to Corrections. And then you'll notice there is when you get to that page, you're going to see this little thing that says More in this section. And this is a drop-down box. And when you drop down, it'll say Training Materials, and click that. And then it'll take you to this page that we are in the process of building just for you. So, and only you have access to this page. Thank you. Next. I want to remind everyone today you're doing symptom management with Marquetta. This is a 1-hour program. Next week is ethical issues we'll be covering, and that's going to take us a little bit longer than the 60 minutes we have devoted. It's actually a 90-minute session. So I want to remind everyone next week's course begins at 1 o'clock as opposed to 1:30. And again, in order to collect your continuing education credit, all you have to do within 24 hours of today's session, of you signing in when we tell you to sign in, you will be receiving an email from us. It's either please check your spam folder, your junk folder, or as we learned today on the Mississippi side, you have to go to that special mail system for outside mail, and you have to allow it to come in. I don't know if you allow it to come in the first time, if you will continue to do that, or if you have to do that each week. I'm not sure. But following today's session, within 24 hours, you will see that email in your inbox, or it will be sent to your inbox, and you have a week or so to fill out that evaluation that we have, this little survey. And then after you fill that survey, you will notice when you sign in and you go to your profile, all of these credits are lining up in your individual profile, so that you can at any point download and print off the certificates that you need to prove that you attended these accredited programs. Video is being made of all of these recordings, and the video is good simply for review. It's not good for anyone who has not attended one of the live sessions. You have to have attended the live session in order to earn the continuing education credit. Having said that, thank you so much, Marquetta. I turn it over to you, and thank you for leading us through symptom management in patients.
Thank you, Jamie, and welcome everyone. As he said, we're going to go through the symptom management module on today. if you don't mind, I'm going to cut my video off. It kind of helps me be able to navigate through my PowerPoint without any interruptions. So today's objectives, we're going to look at some common symptoms associated with patients across the lifespan. Also identifying some causes and symptoms, causes of some symptoms that are seen in the serious illnesses. Going to describe the assessment of symptoms seen in serious illnesses, as well as taking a look at some interventions that can prevent or diminish those symptoms. And of course, hang on. It works when it wants to, sorry. All right. According to the NCP guidelines, I just want to touch bases. There are 3 domains here that we'll talk about, elaborate on during our session, and that's domain 2, which are those physical aspects of care. And of course, during that, the IDT is going to endeavor to relieve suffering and improve the quality of life. The psychosocial and psychiatric aspects of care in domain 3 is where the IDT has the knowledge and skill to assess and support all mental health issues and address those distresses and the quality of life for patients and families. And then the social aspects of care falling under domain 4 is where we have the skills and the resources to identify and address the social factors that affect the patient and the family, quality of life, and their well-being. All right, next the section dealing with some essential elements of symptom management. And of course, during this time, we're going to be looking at just being able to assess and evaluate symptoms, because that's essential to care in any setting. The process is ongoing and it involves evaluation of the effectiveness of the interventions that are provided. The management of symptoms, of course, requires that cohesive interprofessional teamwork that's going to ensure that optimal care is provided. And collaboration is going to be between nurses, physicians, and other members of the healthcare team. That is vital. And of course, when we think about reimbursement and other financial concerns, those are also important factors for some families, and we should consider those as we look at the care plan overall. Continuing research, of course, is always needed to make sure that we are providing and allowing, giving the most relevant information as well. So research continues. And then, of course, with the overall goal of improving the physical well-being, that functionality, and the quality of life for our patients. Sorry. Symptoms and suffering, similar to pain and other physical, psychological symptoms, they create suffering and distress. So in order to be able to treat this, we have to be able to complement the physical pain and suffering with some psychological intervention. The use of chaplains, being able to use social workers and other members of the team, that's necessary to kind of address this suffering. And of course, that would include utilizing across the spectrum of care for the patients. And then also paying attention to the ethical emphasis on beneficence and also the non-maleficence, that's doing no harm and being able to benefit that patient. So symptom management, as it looks into the older adult, currently about 70% of those that die are 65 years of age or older. And most of these deaths are going along with the trajectory of having long and debilitating chronic illnesses. Over 50% of all deaths occur in like those acute care settings where the majority of those patients are older, of course, and their final days are spent in that setting where the main focus is on active and curative treatments and not on assessing and managing symptoms or establishing goals of care. So when we look at that, we know that the majority of the hospice diagnoses are cancer, non-cancer related, congestive heart failures, your chronic obstructive pulmonary disease or the COPD, dementia, and also other illnesses. Of course, social isolation plays a huge part when we start looking at symptom management in older adults, because remember, symptoms can be physical, they can be psychological, they can also be emotional. Some common symptoms that we find in the serious illness realm, of course, these next few slides, we're going to talk about these as they are related to our patients with serious illnesses, where we'll look at the definition and the cause, the assessment, and maybe the management of the symptom if we can, if we could. And of course, we're going to look at respiratory, the GI, the psychological, and also the general systemic system. First, we're going to talk about the respiratory. And of course, covered in this we're going to talk about dyspnea as well as cough. So the definition and overview of dyspnea, of course, includes that breathing is difficult. You know, the patient often describes as being hungry for air. And of course, that's exactly based on what the patient says that it feels like to them, that they're thirsty, they're having to work. They may express that they have tightness in their chest as it relates to them being able to breathe. And of course, dyspnea actually is one of the most reported symptoms with patients in serious illnesses. And of course, the dyspnea can promote disability, that poor quality of life, and also increase suffering in our patients. Some causes of dyspnea, of course, would be the major pulmonary would be tumor, aspiration, pleural effusion, superior vena cava syndrome, pneumonia, could be an embolism, some thick secretions that could be caused by an infectious process or dehydration. And then, of course, looking at some cardiac issues, could be acute heart attack, congestive heart failure, pulmonary edema and pulmonary hypertension, as well as severe anemia and cardiovascular disease. Thinking about some of those neuromuscular causes, the ALS, muscular dystrophy, myasthenia gravis, CVA, and of course, trauma as a result of a physical injury. Of course, some other causes could be anxiety, pain, anemia, ascites, some alkalosis or obesity, even some deconditioning and spiritual issues, those feelings of guilt and issues that the patients may have with trust could also be related to dyspnea. When we look at assessing dyspnea, of course, remember, like I told you, it's the patient's experience, it's what they report. We document it exactly as they report it because, again, they're the ones that's actually going through that. By way of a clinical assessment, of course, that would include the physical examination, as well as sometimes diagnostic tests to be able to take a look at that. And then also being able to better understand what the underlying cause of that dyspnea is. When we think about treatment, should always be focused on improving the function and the quality of that patient's life. In any end-stage disease, we should treat the symptom while assessing whether or not to treat that underlying cause. You know, sometimes trying to treat an underlying cause would include treating like infections or management of, say, a tumor that has progressed. So when the causes are no longer reversible, then we should look at just providing symptom relief to that patient. And of course, some opioids, some pharmacological treatments, of course, could be the opioids as well as the non-opioids to treat that, the dyspnea. Of course, the opioids would be like the morphine, and these are, and of course, can be provided in various ways, the fentanyl, things like that. So the non-opioids could include the benzodiazepines, antibiotics if there's an infection, some anticoagulants if there's a pulmonary embolism, or bronchodilators. Some additional non-pharmacological, of course, is that oxygen, some positive pressure ventilation, interventional therapies, which could also include like counseling and teaching them how to purse their lips and breathe, how to save their energy as best they can, utilizing fans, blowing, just giving the opportunity to let air move around. And then, of course, looking at how we position as well as elevating the bed. When we look at cough, of course, like dyspnea can be very frustrating, and it can also be debilitating for the patient. Cause pain, it could cause them to be overly fatigued, it could even cause vomiting and some insomnia. Patient that has an ongoing cough is also that reminder of them that their disease process is evolving, and it could cause them to even further socially isolate themselves, or it could cause them further frustration and further anxiety. So it's frequently present in advanced diseases like the bronchitis, the CHF, and various cancers. So we just have to keep that in mind, that and the cause of those coughs can be practically anything. It could be the effect of another medicine. It could be the result of chemical or inflammatory, any stimuli in the ears or the nose or the throat. Could also be postnasal drip or allergies, bronchitis. The possibilities are endless for the cough. And so as much as we can, as far as being able to manage that, would be, of course, trying to get to the underlying cause of that. But then also, oftentimes, docs will be willing to provide a cough suppressant if it's applicable for that patient. Next section we're going to talk about is just some GI symptoms. And of course, those are going to include some anorexia, cachexia, constipation, diarrhea, nausea, vomiting, and of course, xerostomia. Anorexia, of course, that's the loss of appetite with that decreased intake. Cachexia is the lack of nutrition and wasting. And of course, please keep in mind in dealing with both of these symptoms, there's some cultural considerations to remember as it relates to that patient's culture and how they believe or how it relates to things around their eating, as well as some ethical implications, the benefit versus the burden, things of that nature. And we'll go into that just a little bit more as we move further into the subject on today. Of course, let me say this, in both of these, weight loss is present. And of course, this increases that distress in that patient. Also could mess with their self-concept or their image, as well as, associating with a decreased survival. They don't want to perform. They don't, it just decreases their whole quality of life or their whole outlook, because I guess from a visual standpoint, impending death is kind of looking back at them. So that's something to keep in mind as we start thinking about the cultural implications of that. And I guess I've needed to speak a little bit further as far as the ethical implications, because you ask yourself, as a society, we tend to want to feed people when they're sick. How can you, from an ethical standpoint, being able to feed them because they can't eat, or eating causes them to be sick? It kind of gets in the puts us at a crossroads of, if I'm not feeding, if this patient's not able to eat, then there's an increase in the suffering. But then you have to weigh that against what it looks like if that patient were to attempt to eat and then feel worse behind that. Some of the disease-related anorexia and cachexia are likely due to the stimulation of the pro-inflammatory cytokine production and some other metabolic abnormalities. There are multiple causes of anorexia in the terminally ill patients. And of course, that could include being disease-related, seen most frequently, of course, in cancer and congestive heart failure, and even COPD. Some oral or systemic infection, like candidiasis, it could also cause discomfort when they're eating, so they don't want to eat. Pain that associated with eating can also occur with certain diseases or issues such as pancreatitis. And of course, a patient that has like chronic nausea and vomiting can be caused by treatment, medications, and also disease progression. Constipation may be considered a tumor burden. Medications, decreased fluid intake, and of course that inactivity. From a psychological standpoint, depression exhibits many somatic symptoms. That includes anorexia. The change in the self-image actually can affect them from a standpoint of how they feel about themselves. And of course, the weight loss is apparent. And then keep in mind that as a patient is not eating, their energy decreases as well. That also has an impact on their psychological being. From a treatment standpoint, certain treatments that they have or medicines may change the taste of food, and it gives them an aversion to food where they don't want to eat. Radiation therapy, of course, including bowel strictures, fistulas, these things can be problematic for patients even after they've had like the radiation going on. And of course, a patient that has had surgery of the bowel, that can result in them having like short gut syndrome and other digestive issues whereby eating is not something that they want to do. When we look at being able to assess anorexia and cachexia, we're going to have to focus on the understanding of that patient's experience and their concerns, and determines whether or not there's potential reversible causes. Of course, that patient history is used to identify that patient that has a weight loss from where their foundation weight was. We kind of pay attention to that to kind of see where they're at. Also looking at some physical findings like that physical exam and that assessment of paying attention of like the weight loss or the muscle wasting, the loss of strength, decreased energy, decreased fat, and also make sure that edema can mask some wasting. So we also have to do things like pay attention, look inside their mouth to make sure for, any kind of painful lesions that they may have or any kind of thrush going on. And of course, discuss that patient's perception of and the response to the symptom and on the quality of life. Have to be able to have those conversations because families sometimes become really upset and frustrated when their loved one will not eat, because in our mind, oftentimes the reality, the idea is, if she would just eat something, she would feel better. So we have to keep that in mind as well. Also, of course, evaluating that patient, like I said, for their decrease in their intake of food and their fluid intake. Calorie counts, of course, sometimes can be considered as well as weights. And of course, being able to use these assessments, they have to be continuously looked at as late in the disease. They may not even be necessary. So, and we don't want to create a bigger burden on the patient than necessary. And sometimes some lab tests can, of course, be taking a look at that albumin just to see kind of where, from a laboratory standpoint, where that patient stands. And of course, we always have to evaluate patients that have anorexia and cachexia and decreased intake for skin breakdown and have to address that accordingly. When we look at treatment for anorexia, of course, we want to always make sure that the patients are encouraged to eat whatever they like, their favorite foods, foods that are easy to chew, some sauces, some gravy, whatever it takes to get them to eat when they can. That will be, that's encouraged. Also, forget about a restriction. At this point in life, dietary restrictions, if a patient finds that they're able to eat ice cream and that's all they can eat, please allow that patient to have ice cream, because at this point, restrictions are kind of out the window. Of course, encourage also high calorie foods in those little small meals. That kind of also sometimes improves the intake, as opposed to saying, having 5 or 6 tiny meals and trying to have 3 large meals. From a medication standpoint, there's no single pharmacological intervention that's effective for cachexia. However, they can be improved over the last decade, according to research, by incorporating some dietary modifications and exercise as available with selected pharmaceutical agents, like those appetite stimulants, looking at Marinol and Megestrol and things like that. Those sometimes are able to be utilized. Olanzapine or Mircapine can also be helpful in increasing some intake. Some prokinetics may be helpful in increasing the gastric emptying if that's an issue that the patient is having. And of course, some other agents that may prove successful, such as alcohol or a glass of wine before meals, corticosteroids, ARPs, EPAs, things like that may be indicated. So, and of course, cannabinoids, we definitely can't leave that out, because that's been proven by research to improve appetite and also mood, but it doesn't provide weight gain. So the 2 most used and approved of the U.S. Food and Drug Administration are drobenolol and nabulol. So that's the 2 ideas behind the cannabis. Also got to keep in mind that problem odors that inhibit eating can be addressed by kind of cooking separate from eating, because sometimes the smell of food can make patients sick. So maybe cook you know, the meal time comes after the preparation time, much further down, so that the patient will have an opportunity to hopefully be able to control the smell of the food so that they can, eat. And then, of course, counseling as much as possible, educating the patients and the families, about anorexia, cachexia. That's important. That's just an important nursing rule as well. Just being able to make sure that they understand um, the causes of those. Moving forward, looking at constipation, of course, that's that infrequent or difficult passage of stool. It's a frequent symptom when we look at patients that are in palliative care, end of life. And of course, making sure that we get in front of that as best we can to kind of prevent it as much as you possibly can. Some causes of constipation, of course, are the disease related, that obstruction, hypercalcemia, neurologic, and of course, just being inactive, being in the bed, not able to get up and move around, of course, is some causes of constipation. And then, of course, some treatments. Sometimes the side effect of some of the treatments that we provide for patients would be like those opioids, the painkillers, that side effect of that is constipation. Being able to assess constipation, of course, that's being able to understand their bowel habits, their history of their bowel habits, as well as doing an abdominal assessment, kind of palpating to see. I know that oftentimes with constipation, you can almost feel it, especially in the patients that have lost quite a bit of weight. This is something that's easily palpated. Of course, also there's times where there's a digital rectal assessment that could be provided, as well as being able to review the medicines that the patient are on, just assessing seeing what medicines in addition to what they're prescribed. And of course, I know that may not be an issue with you guys as far as some of the over-the-counter things that patients normally take that could cause constipation as well. Treatment of constipation, of course, are medications, some other approaches that could be looked at that as far as dietary and fluid interventions. Also, patients remember that prior to being sick, patients already had a bowel regimen. And so just trying to be able to understand where they were, what was normal for them, prior to becoming sick kind of helps. But then also making sure that we are able to prevent as much as possible. And of course, that's in educating the patient, educating, increasing activity if it's even possible. And of course, increasing that intake, fluid intake as much as possible, using prophylaxis laxatives whenever there's opioids being used, and of course being able to just provide privacy for defecation. Diarrhea, that's the frequent passage of loose and non-formed stools, and of course the effects, of course, are fatigue, caregiver burden, and of course that skin breakdown are definitely some issues. Causes of diarrhea, of course, could be related to the disease process. It could be malabsorption, concurrent diseases, along with what they're actually going through. Psychological could cause some diarrhea, as well as treatments that they are receiving that could cause diarrhea. Of course, being able, kind of the same way to assess for diarrhea as well, is getting that bowel history, understanding their medications that they are on, as well as that physical assessment, and then also understanding the infectious processes. Treatment of diarrhea, treating that underlying cause or whatever it is that is actually causing the diarrhea, as well as modifications of the diet as needed. Of course, hydration, because of course, loose stools over a long period of time can definitely cause dehydration. And then of course, the pharmacological agents that could be related to treating diarrhea. Looking at nausea and vomiting. Excuse me. Those are two of the most dreaded side effects of medicine and diseases and or treatments, because it can not only be taxing physically, but it can also have an impact on patients psychologically. I've heard people say, I'd rather do anything than to vomit or to feel like I'm about to be sick. So it can be very, very taxing over the patient. And of course, but this is common in the advancement of several diseases. And of course, being able to assess the etiology or where the nausea and vomiting is coming from, that's vital to be able to treat that. And of course, it can be, of course, acute, anticipatory, or even delayed from a delayed standpoint. Some causes of nausea and vomiting, of course, could be GI, metabolic, or CNS system could be involved. Psychological, related to the disease process that they're in, and also from the treatments that they're receiving. Of course, physical exam is going to be important to assess also the history. Oftentimes, lab values are drawn just to kind of see where that patient stands as far as, especially over an extended period of having had nausea and vomiting. And then, of course, well, being able to assess their level of dehydration, making sure that they're able to stay hydrated. Excuse me. Some pharmacological aspects or some ways to actually treat that vomiting, of course, is going to be through anticholinergics, antihistamines, some steroids, prokinetic agents, as well as other. I was trying to think if I could come up with another. It'll come to me in a minute. Some non-drug treatments for vomiting. Of course, just being able to get that patient to relax, and even some distraction methods to get their mind off what they're actually, going through. Modifying the diet, and also some invasive therapies as well. Oh, sorry. IV hydration, of course, when the nausea and vomiting is severe, should be considered. Also looking at, an aggressive bowel regimen that's for constipation. Of course, in the hospital setting or in other settings, of course, they would also look at things like steroids, radiation for, patients that have the brain metastases and things like that going on that cause the vomiting as well. Xerostomia, of course, that's that dry mouth, difficulty in swallowing and can't speak very well because of the dry mouth. Of course, this can be caused by meds, by radiation, and even by other systemic diseases. And in order, of course, to manage this, we're going to have to take a look at modifying the medications that they're on, as well as looking for the underlying cause, providing soft, moist foods, immaculate mouth care, which would include, frequent brushing of the teeth or brushing the tongue even, and even providing some, sips of water, or able to suck on ice, or keeping the room humid, believe it or not, is kind of also beneficial, as well as being able to allow that patient, as applicable, to kind of suck on some sugarless gum. A hiccup, of course, that's that sudden involuntary contraction of diaphragm and the intercostal muscles. Highest prevalence, of course, is with GERD and gastric distension. Can be associated sometimes with medicines taken like the corticosteroids, as well as the benzodiazepines. Psychosocial considerations, of course, can be related to the to depression. We're going to look at that. We're going to look at anxiety. We're going to look at PTSD, and then also some delirium, agitation, and or confusion. And of course, being able to assess and manage these psychological issues in the middle of going through, when a patient is going through serious illness, it can really be challenging. Things that we're going to have to consider, and we'll talk about this a little bit more, is the culture, how long they've been sick, some managed care issues, and cost of healthcare, of course, and also the most important factors to consider, of course, when looking at psychological issues are, coping mechanisms, what has worked, what's worked in the past, the stability of that patient, the emotional stability, the support, and also the symptom distress. When we look at depression, of course, that could go from just being sad to absolutely being suicidal. It's oftentimes one of those issues that are under-recognized as well as undertreated. Of course, in 25 to 77% of the terminally ill suffer from some level of being depressed. And of course, there's a distinction between normal depression and abnormal. Depression in any manner should not be dismissed. The disease itself, of course, could be a cause of the depression. Psychological issues, the idea of going from being able to provide care for themselves or to be able to take care of themselves to just being able to be going to being totally dependent upon someone else to take care of them. Of course, medication side effects sometimes can cause depression. Treatments sometimes can cause depression, as well as the idea of, here I am and I'm sick. I can't get to my family. I'm here. My family's out there. You have to think about that in terms of a patient that's in corrections. And so those could also be some issues that could be related. Not just a phone call away for, a family member to come and be with me during my time of illness. So that's something to keep in mind if those patients typically go through. Of course, the assessment of depression is going to relate to those situational factors or the symptoms. Also taking a look at that patient's previous psychiatric history. And of course, again, like I said, the pain, the lack of having a support system as well are things that we look at in order to assess that patient's depression. From a standpoint of a suicide assessment, and of course, what happens there, just checking out the risk factors for suicide, keeping in mind an idea of understanding the declining history of functionality within that patient, like where they actually have come from as far as, or declined to, I should say, as far as being able to function. And of course, as well as also taking a look at the psychiatric evaluation. So I guess when I think about the suicide assessment, I just want to mention that some questions that, just thinking about, it would not be unusual for someone in your situation to, have thoughts of maybe hurting yourself. Have you ever had thoughts like that? And then remember, patients that have those long-term threatening illnesses, they're going to experience some sadness and grief and even some loss and grieving functionality that they used to have, or grieving the fact that they can no longer take care of themselves. So those are things to keep in mind when we start to do like an assessment and think about what the patient is actually feeling from a psychological standpoint as they're actually going through. Some pharmacological interventions for depression, of course. The goal is always to focus on that symptom control. So, there's antidepressants that, doctor may prescribe. Just keep in mind that some of those may take several weeks in order to be effective. Also, steroids like the dexamethasone, and then the psychostimulants like the methylphenidate. Some non-pharmacological interventions are things that we can look at to treat depression. Of course, that's promoting that autonomy, as much autonomy and control as possible, encouraging that patient to, participate in care as much as they can, have that sense of control, give options, something simple, would you, do you feel like eating this Jell-O by yourself, or would you prefer to have someone kind of assist you? Sounds simple, sounds really small, but you wouldn't believe the impact that it would have on a patient as it relates to a patient that's struggling internally with being in control of their self and being sick. So those are things that we have to keep in mind. Grief counseling, of course, can also, assist that patient to deal with things that they've lost, things that they feel like they're losing right now, and then just looking at what the future actually looks like for them, just being able to talk through some of what they're going through. And of course, drawing on the strengths that that patient still has, even at a loss from a physical standpoint, we try to dig down and find some strength, something positive to be able to, for them to be able to rely on. And of course, providing like some cognitive strategies, like some relaxation techniques, reframing negative thoughts to positive thoughts. And then of course, like meditation or mindfulness, prayer, yoga, music, those are all things to consider. But of course, we have to consider that individual patient's cultural standpoint. Anxiety, of course, is subjective. It's a feeling of that apprehension or tension, uneasiness or insecurity. And it doesn't necessarily have to have a cause. They don't have to have a reason to be anxious. Sometimes just a thought will cause us to have moments of overstimulation, and then we become anxious, and then we become tense, and then sometimes it just cycles from one thing to the next. So it doesn't necessarily have a cause. Of course, anxiety is categorized as mild, moderate, or severe. Some of the causes of anxiety will include some psychological changes. Of course, that could be related to the treatment that they're getting. It could also be some pre-existing, some things that they've had before their diagnosis, some uncertainty, because it's understandable that, along with the illness, along as they go along the illness trajectory, that people that have life-limiting illnesses, they're going to experience some anxiety. A lot of things to be anxious about. Like I said, the prognosis, their mortality, if they have some spiritual issues, some concerns as far as family, even if they're having uncontrolled pain. So, and then we also have to consider contributors to anxiety. Could it be, some spiritual distress? And so please keep in mind that we want to plug in those chaplains as much as possible. And of course, some major risk factors as it relates to anxiety could be those heart issues, or the COPD, or the pulmonary issues where breathing and things like that are difficult. To assess anxiety, of course, we're going to take a look at those physical symptoms, as well as being able to look at those cognitive symptoms, or, those that would include like those recurrent and thoughts or ideas, the fear of, going crazy, or having come apart as it relates to being able to, I'm dying and I can't do anything about it. And of course, sometimes treatment depends on the etiology of where these actual symptoms actually come from. Some questions, of course, for that assessment, pretty simple. Just what's your biggest fear? And what is it that's got you worried right now? From a standpoint of medicines, of course, there's benzodiazepines that could be prescribed for anxiety, as well as antidepressants. Of course, got to be careful with those for older, frail adults, because they could cause oversedation, put them at a big risk for falls, and also disturb their sleep. Some non-pharmacological or non-medication things that they can do for anxiety, of course. That would include, being able to acknowledge that they're afraid, using those open-ended questions that's going to give them a chance to speak and kind of express from a standpoint beyond just yes or no questions. And of course, being able to listen empathetically, provide that assurance and support as best that you can. And of course, just getting that concrete information and warning, as well as some relaxation and imagery. And I will say this, that, sometimes tagging in and allowing the chaplain, or allowing the social worker, or a combined approach to be able to address that patient specifically where they're at. Keep in mind that oftentimes you may have to lean back and go back to some of their cultural considerations, or some things that patient, some of their beliefs and their values prior to getting sick, will kind of help getting to that point of when they're dealing with things like anxiety. PTSD, of course, that's characterized by that severe reaction to a traumatic event, as it could be related to, previous attacks or combat, assault, whether it be sexual or physical, accidents, big disasters, and of course, system clusters could include like avoidance or re-experiencing that event over and over again, or being hyperly aroused. And of course, implications for end of life. We'll touch on that just a little bit. Delirium is that acute change in cognitive, or no longer being aware. Agitation or withdrawal, of course, that comes along with that delirium. And then confusion, of course, is just that disorientation. Sometimes it could be inappropriate behavior, as well as hallucinations. Some risk factors: medications, of course, infection, hypoxemia, some bladder distension, pain that's unrelieved, could also be cause for agitation and delirium. Also, think about, let me just say this, patients that are at and I don't know that you guys would see this, but I just wanted to say that I have seen delirium take place in a patient that maybe they have been restrained to keep from pulling tubes out. And it instantly, just something about that restraint or something about the ability not to be able to move when I want to can actually cause that delirium. Also, you have to think about the thing of positioning. A patient that from a normal standpoint has, in times that they were well, were up and moving and very mobile, to be bedridden can also cause some confusion, some delirium, or just not being able to cope with their present situation. And of course, the assessment is going to be looking at that history, also understanding from a spiritual standpoint and identifying whether or not they have any spiritual distress going on. And also looking at, of course, that patient's physical exam. And then also, of course, some lab tests may be needed. Treatment, going to maintain the patient's safety. There's some pharmacological things that could be given, some atypical antipsychotics, benzodiazepines, haloperidol. Of course, we're always monitoring for side effects or withdrawal. Eliminate non-essential and contributing medications. Want to always reorient, keep that patient reoriented to where they are and kind of what's going on, as well as providing some relaxation or distraction, and also, again, making sure that the patient stays hydrated. Next section, final section that we're going to deal with today, of course, is looking at some other symptoms, just some generalized symptoms. And here you'll see fatigue. That's that subjective, multidimensional experience of just being exhausted or tired. Of course, the disease can cause this, treatments can cause this, and even some other psychological factors can cause fatigue. Of course, keeping in mind that assessment, both of subjective and the objective, through a review of even just looking at lab data, just saying that both assessment, subjective and objective. So basically it's going to be what the patient tells you as well as what you can see when you examine the patient. Then, of course, we'll look at the treatment. The treatment of fatigue, of course, just looks at being able to provide support, being able to allow them to help them to conserve energy as best as possible. Of course, keeping the patient calm, of course, because if they're anxious, if they become anxious or excited, that, of course, expels energy. So just being able to keep them, and then also just being able to, they may take twice as long to eat, as eating very well may tire them out. Things that seem on the norm. So just being able to conserve energy, take small steps to provide care instead of, aggressive steps or things that would actually tire the patient out. And then also being able to allow that patient as much as they can to give you feedback on how certain treatments affect them. Wounds, of course, are that loss of skin integrity, could be caused by pressure injuries or ulcers, malignant wounds, or even Kennedy terminal ulcers. Of course, when we're looking at assessing a wound, we're going to look at the characteristics of it, how much pain it causes from a psychosocial aspect of the wound, how that affects, and then also looking at the caregiver, because you have to keep in mind those that are taking care of the patient as well can be impacted by those wounds. Treatment of injuries, that's changing the positions frequently, making sure we're clean and dry, making sure, they're not in any pain from that. Consult, of course, as needed, and of course, getting in front of it, preventing it is the key thing. Wounds in patients with life-limiting illness, of course, we're always going to try to assess that underlying cause, as well as checking out the goals of care, of course, whether or not it's even realistic that that wound is going to heal. Manage pain and also odor, because keep in mind that outside of keeping pain under control, we want to also protect that patient from a standpoint, from an emotional or psychosocial, because their wound or their odor sometimes is emanated from, severe wounds, or, just odor from the body itself as, systems begin to shut down. To be keep in mind. Seizures, we'll look at definition and causes. Of course, we know that a seizure is that unexplained, sometimes unexplained, a manifestation. Of course, could be an aura, an acute, a gradual, onset, could be mental status changes, motor movement changes, and then as well as sensorial changes. And of course, an exam includes just orienting that patient, speech fluency, registration, cranial nerve evaluation, motor function, a sensory exam for trauma to the mouth or the tongue. Of course, what you want to do is, limit trauma as much as you can from the standpoint of, the seizure, not allowing them to hurt themselves, anticonvulsant treatment, the phenobarbital, lorazepam, diazepam, and the levetiracetam. Sleep disturbances, of course, they affect the quality of life for the patients as well as those that are taking care of them. Poor pain and symptom management, of course, can lead to major disturbances in sleep. It's a frequent occurrence in critical care or life, end of life situations. Just want to make sure to assess with that history and physical of that patient. Of course, if pain, anxiety, or any of these symptoms are present, check and see as far as their medication. There's also cognitive behavior therapies that can be considered. Some music, some reflexology or mindfulness, of course, can be also some things that can be utilized to help with the sleep disturbances. Lymphedema, of course, that's that chronic progressive swelling due to failure of the lymph drainage. And of course, puts patients at risk, includes, those that have had some lymph node situations, surgeries around lymphatic chains, and of course, infection that involves the lymphatic system. And of course, keep in mind with the side effects as well as symptoms is like that heaviness, discomfort, low range of motion, those stasis ulcers, body image and quality of life issues are very, very, very common. These. One final reminder, of course, be aware of symptoms of urgent syndromes. And of course, that's the superior vena cava obstructions, pleural effusion, pericardial effusion, hemoptysis, spinal cord compression, and hypercalcemia. Be more familiar. Just try to be familiar with those syndromes as they occur frequently at the end of life. In conclusion today, symptom management challenges are challenges for us all, for the entire team when you start thinking about providing care to patients at end of life. Lots of symptoms are common. Keep in mind that we have to coordinate our care. Nurses got to work closely with the entire team to make sure that all treatments that can be provided for that patient will be. Also utilizing drug and non-drug treatment, as well as, teaching that patient as you go along, educating them, and also providing them with support. That takes care of our slideshow for today. I'd like to make sure that no one has any questions as it relates to anything regarding symptom management.
And again, I want to remind everyone in corrections that whenever you encounter a symptom that is particularly perplexing, you can contact us, and while we may not have the answers, we will put you in touch with hospices across Louisiana and Mississippi who have been dealing with these symptoms for the past, well, we've been doing hospice here in Louisiana and Mississippi for the past 40 years. So they will, with somebody, we have a wealth of knowledge in terms of alternative ways of dealing with symptoms that maybe your formulary inside of corrections isn't allowing for. Okay, any questions of Marquetta before we move on? I know it's 2:30. Just want to make sure. Real quickly, I'm going to share my screen. I just want to show you one thing. This is our website. When you come to our website, you have to come up here and sign in. You put your username here, and your computer may require secondary authentication. Oops, that's wrong one. Let's sign in again. No, I'm sorry. There we go. I have lots of sign-ins. When you get in, then you'd hit the logo at the top, and it's going to take you to the front of the page. You go to professional resources, you come down to corrections, and it's going to take you to the corrections page. And then this is that little toggle I was telling you about. All of the material that we've been covering is going to be listed. This will take you, there are 3 pages of correctional stuff, and you can simply move to correctional training material. And you'll see as we are going by, we're going to be loading up all of these with the videos of each one of these sessions along with the handouts, so you can constantly refer back to that information, or you can constantly call us, either myself or Marquetta, and we'll put you in touch with the person that you need to be in touch with. Okay, so thank you. We want to thank you for your time and attention today. Remember, next week we will be meeting at 1:00. And right now, I'd ask everybody who's attending and would like to receive continuing education to please go to the chat box, type in your name and your email address. And with that, we will see everyone back here next Tuesday after Easter. Have a wonderful Easter Passover celebration this weekend, and we will see you all back next Tuesday at 1:00. And where we'll be talking about ethical issues that arise in end-of-life care. Thank you again.
Thank you all.
Take care.
Thank you, Marquita.
Thank you. Have a
Once you put your name and email address into the chat box, you can disconnect. Is there anybody else who needs to sign in with your name and your email address? Wait one more minute and then we're going to close it out.